Hi, everyone. I'm Patrick Wen from the Center for Neuro-oncology at Dana-Farber Cancer Institute. And it's a pleasure for me to moderate this session, which will focus on treatment monitoring, radiologic assessment, and current protocols and future directions. We have a wonderful panel. Dr. Ali Nabavizadeh, who's an assistant professor of radiology at the University of Pennsylvania. Dr. Max Wintermark, who's professor and chief of neuroradiology from Stanford, and Ben Ellingson, who's professor of radiology and psychiatry from UCLA, and who's done a lot of the really important work in response assessment in brain tumors. So I think that this whole symposium is directed at finding better treatments for our patients with brain tumors using focused ultrasound. And a critical part of this is determining benefit from these treatments, trying to determine response and progression. And that's a major challenge, I think, particularly with this technology. Maybe I can ask Ali to begin and just talk a little bit about some of the challenges.
Thank you, Dr. Wen. I want to thank the organizers for having me as a part of this discussion. So as you mentioned, and I think in many of the previous panels was mentioned, monitoring the treatment response and post-treatment GBM is a major challenge. And there has been significant efforts in the past couple of years in terms of really trying to optimize and standardize that using Raynor and recently modified Raynor, which have been very helpful. But at the end of the day, I think we're dealing with a disease that conventional MR is not very reliable. And patients could go on for months with ambiguous imaging. And so adding the complexity of different treatments, precision-based treatments, immunotherapy, and focused ultrasound for drug delivery, I think that we are dealing with a lot of unknowns in a sense that, for example, when we want to treat a patient with focused ultrasound, we have to first decide what part of the tumor are we treating. Are we treating the enhancing part? Are we treating the infiltrative component, which is present on FLAIR but not enhancing? Or are we also targeting the areas that are beyond the MR? And maybe if we do amino acid PET, we could see those components. So I think these are very important questions that needs to be answered. And also for drug delivery, we know that we're using gadolinium-enhanced MR as a biomarker for blood-brain barrier disruption. But we know that that mainly correlates with small molecules. But how about if you want to use antibodies or cell-based treatments or nanoparticles for treatment or viral treatment? So we need to really, I think, embrace experimental imaging in this kind of endeavor with focused ultrasound and see how we can use these imaging techniques to better understand the tumor microenvironment during these treatments.
Thank you. I think finding novel ways to monitor the delivery, the improved delivery of whatever treatment you're trying to improve the delivery of is critical. Dr. Wintermark, I don't know if you have any comments in this area and perhaps some of the work that you've been involved in.
Yes, so I agree with everything that Ali mentioned. I think glioblastoma is an heterogeneous disease, both, from patient to patient, but also for one specific patient, different region of the tumor may have different characteristics, different microenvironment. That's something that was mentioned in the previous session. And I think that we indeed need tools to understand better that microenvironment in different regions of the glioblastoma in each individual patient. And of course, imaging is one of those tools that is potentially available. We have some pretty good, so Ali mentioned the basic MR imaging. We also have advanced imaging techniques, and I'm sure that Ben will be happy to comment on those. We use those advanced imaging techniques on a routine basis, and they provide a lot of insight on the brain tumor microperfusion on a regional basis. So I think we already have learned a lot. But as Ali mentioned, there are still a lot of things that we don't know. And when we try to evaluate a new treatment like MR-guided focused ultrasound, especially at the beginning, we need to understand as much as we possibly can. And that's when those other modalities such as PET with specific tracer might potentially be helpful. And then in the long term, we'll have to, after this initial phase where we try to understand exactly how it works, then we'll need to come up with a very practical imaging biomarker that can be obtained on a routine basis in order for the treatment to be disseminated as widely as possible.
Thank you. I mean, one major hurdle that seems, ideally, if you could tag a drug or an antibody and see improved uptake in the brain with PET, that would solve a lot of problems in terms of trying to understand the efficacy of this approach. And I know there's been a lot of work at Stanford and elsewhere doing this, but trying to get it to be done practically on an everyday basis seems to be a huge hurdle. The need for INDs and all that. Do you see a way forward that we could make it more readily available so that this can be something we can do for many studies rather than for the rare studies?
And in my mind, again, I see two phases, because the first phase, we need to investigate those different options that we have, and there are many, to figure out the one that works really well. And then the second phase will be to try to make that option that works the best available. Sometimes also in the world of imaging, there are things that you do in early trials that really help you understand what works best. And then you can find some kind of proxy. It's perhaps not exactly the same information that you get, but something that is close enough that then you can use it in a more standardized manner. So I think really, in my mind, there are those two phases where, first we have to find the molecule that works the best. I don't think, that is done just yet. And then once this is identified, then to find a way either to use that molecule widely, or to find some kind of proxy that will provide somewhat of the same information, but that will be easier to obtain, again, in a broad disseminated way, not just at some very specific centers.
I mean, ultimately, we want to know if the treatments are working better with focused ultrasound. And so having accurate response assessment is critical. Ben, you've been a leader in trying to develop better approaches in developing response criteria. Do you want to talk a little bit about the challenges and how you see how can we address this really important issue?
Yeah, sure. So I think that one of the fundamental questions is really what we're trying to what are the questions we're trying to solve. So, for example, if we're trying to investigate whether or not focused ultrasound can open the blood-brain barrier, I think we have adequate tools to kind of do that, right? Gadolinium-based contrast agents, dynamic contrast enhanced MRI to look at K-trans and vascular permeability. But those are sort of transient events during that treatment window. If we're going to be looking at sort of long-term changes in the bulk tumor, I think we can still use sort of classic response assessment sort of technology. So the modified Raynor, for example, adding on to the current Raynor criteria, just requiring confirmation that the tumor is growing, kind of mitigates some of those issues. But I also think in the early phase, when we're talking about, is drug getting in, is it activating the target? I think we have, technologies to do that. You mentioned radio labeling drugs. We can look at PET tracers as well, but also looking at sort of downstream target engagement. So, for example, are we changing the metabolism of the tumor after the drug is getting in? I think can be also a surrogate of sort of benefit. So I think it depends on the questions we're trying to ask. I think first we want to know is how focused ultrasound can be sort of optimized to get drug in. Then, looking at whether or not we have target engagement, biological changes, and then, we're talking about phase 2, phase 3 studies looking at efficacy. I think we still have adequate tools. They may not be perfect, but contrast enhancement is a pretty good surrogate of disease burden in GBM in these fast-growing tumors. So I think we have the tools to sort of mitigate these things and explore them even clinically.
I think most people are familiar with the modified Raynor criteria, but for those who may not be as familiar, do you want to just briefly outline what that involves?
Yeah. So basically, the fundamental difference is instead of the first evidence of disease progression, whether that be a tiny bit of non-measurable enhancement or even tumor growth just more than 25%, the idea is that to sort of wait out the storm in order to look at transient changes and actually confirm progression. So very similar to sort of RECIST criteria and other sort of immunotherapy-based response assessments, just trying to confirm that the tumor is growing beyond some initial transient change. That allows us to kind of have more confidence that the tumor is continuing to grow and is not controlled by the drug, and it isn't sort of a pseudoprogression inflammatory type response. And I think we have evidence now that it's pretty good for the management of patients on trials, as well as it seems to predict, progression-free survival seems to be a pretty good surrogate of overall survival, at least in GBM.
Thank you. One of the issues that will come up with this type of approach is this issue of pseudoprogression. So in addition to having more robust criteria like the modified Raynor criteria, imaging of pseudoprogression ideally would be better. Ali, do you want to talk a little bit about some of the approaches that might be used to look at this, that could be incorporated in some of these focused ultrasound trials, for instance?
Sure. I guess if I'm understanding correctly, your question is tailored toward how can we differentiate progression from pseudoprogression with current approaches. And I think that there are a couple of ways to do that. One thing that we have experienced at Penn is using amino acid PET tracers using flucyclovine. I know that, Ben, you have experience with FDOPA at UCLA with this, but this is something that we have been found to be helpful in differentiating progression from pseudoprogression. And there are other techniques. People use AI-based approaches and machine learning-based approaches to differentiate these two. So there are a couple of ways to do that, but I agree that it's a major problem. But I guess getting back to your previous question, I think that there are a couple of low-hanging fruits here. And if we do the studies, targeted studies in pre-surgical setting using experimental imaging, we have the opportunity to test our hypothesis that whether if we think that if we use a PET tracer and we think that the drug is getting into the tumor, we have the opportunity to actually look at the tissue and see whether it actually happened. So I think that we have to really do these studies, do our homework with these experimental agents to better understand the efficacy and of these imaging studies that are not very commonly used.
There's a question from the audience asking, how can we evaluate blood-brain barrier opening in white matter? And is gadolinium a good surrogate in this location? Maybe Max, do you want to comment on that?
So here I work at Stanford, we routinely use both dynamic susceptibility contrast DSC imaging and dynamic contrast enhancement DC imaging. And we assess the opening of the blood-brain barrier using K-trans calculated from DC imaging. I think it's a pretty good technique. It's a pretty good surrogate to assess the baseline opening of the blood-brain barrier in the different portion of a GBM. It can also help potentially assess the effect of the focused ultrasound. One limitation that Ali mentioned earlier is that the gadolinium is a small molecule, and so the image that you get is the permeability of the vessels to a small molecule, and that doesn't necessarily predict exactly the permeability of the blood-brain barrier to a larger molecule like a drug molecule. So there are some limitations, but I think it's a pretty good surrogate that gives us some quite useful information on the microvascularity of the GBM. And I don't know if Ben wants to add anything to those statements.
No, I think you're absolutely right. I mean, I think gadolinium-based contrast agents, looking at dynamic contrast enhanced MRI and using K-trans, which is sort of the forward rate constant or the flux of the contrast into the extravascular space, is well established and a good surrogate. But you're also right that it's only sensitive to basically blood-brain barrier opening to the size of the molecule, right? So I think, as Patrick alluded to earlier, if we were able to sort of radiolabel drugs, radiolabel antibodies, for example, temozolomide or, bevacizumab or nivolumab, we might be able to see how well the blood-brain barrier opening can allow larger molecules, even albumin and things like that. We might even look at changes in T2 or edema, because we would expect, with severe opening of the blood-brain barrier, we might see movement of water into the extravascular space. So you might also look at sort of what's happening, within white matter in terms of water permeability and different things like that. So I think there's a variety of techniques, but gadolinium-based contrast agents is probably the easiest to implement. People are doing it routinely, and it would be, my suggestion to try first, of course, before these exotic, expensive methods.
And that's what I was alluding to earlier when we are talking about proxy. You indeed with gadolinium, you look at the permeability of the vessel to a small molecule. It doesn't necessarily tell you exactly what's going to happen with a large molecule, but it still gives you some useful information. If the K-trans for a small molecule is very increased, that tells you that a large molecule is more likely to go through. Whereas if the K-trans is not increased or increased only a little bit, probably it will be much harder for a larger molecule to go through. So again, perhaps you don't look exactly at what you're interested in, but you have a good proxy that gives you some useful information. And again, the advantage of those techniques is that they are relatively easy to implement, to disseminate, and a large number of sites would be able to perform them.
I might also just comment, trying to think about the timing of how we would do this experiment. So if we think that this is transient within like 2 hours or so, how we time the treatment with the focused ultrasound, the drug delivery probably has to be infused at the same time. And if we're going to also monitor it with MR, we're talking about doing all of these sorts of things in a closed space, physically. So logistically, it might be, relatively difficult to show all of these things kind of at the same time, deliver drug, deliver the ultrasound, and monitor within a window. So I think that's going to be a real big challenge that we'll have to try to think about as well.
There's one other question from the audience asking about the role of focused ultrasound in pseudoprogression and whether, I guess interpreting the question, whether it can be used to enable things like liquid biopsy to help us with determining whether it's progression or pseudoprogression. Does anyone on the panel have a comment on that?
Yeah, I mean, if I understand it correctly, the idea is that by opening the blood-brain barrier transiently, you may allow sort of free cell DNA or other sorts of things to enter the vasculature or CSF or whatever. So it would allow us to kind of sample that. I think that's a really interesting idea. Again, comes back to what area of the tumor do you think you're opening, and whether or not there's going to be enough of that material kind of in the extravascular space that can enter the bloodstream. I think it's an interesting idea.
Great. Well, thanks so much, everyone, for this wonderful session. I think there's going to be a short break now, and then the program will resume. Thank you.